We are live.
Thank you. Good evening, friends and mentors, and welcome to this 14th episode of our All India Postgraduate Teaching Program, which is a new initiative from our ARC AIOS. This is a PG program with slight difference covering the uncovered aspects. We had two short cases in pediatric ophthalmology. One was infantile esotropia and one was Duane's retraction syndrome. Today here we present in the 14th episode of our series, the third journal club. Today at Department of Ophthalmology, AIIMS Rishikesh. And the second article would be presented by Dr. Priyanka Jain, who is again a DNB resident at Sadguru Netra Chikitsalaya, Chitrakoot. My special thanks to the mentors from AIIMS Rishikesh, Professor Dr. Anupam Singh ma'am, and also head of the department, Dr. Sanjay Kumar Mittal, for sparing the time and getting the students ready for this particular occasion. Also, I'm thankful to the mentors from Sadguru Netra Chikitsalaya, Chitrakoot, Dr. Chintan Shah, and head of the department, Dr. Pradnya Sen. My special thanks goes to the special commentators today, Dr. Ramesh Kekunia, who is a director from Child Sight Institute and Technology Innovation Bionest, LVPI, Hyderabad. Dr. Sujata Guha, a colleague, she is a peer of mine from Shankar Nethralaya. Right now, she is a medical director and senior consultant pediatric ophthalmologist and neuro-ophthalmologist at Aditya Birla Shankar Nethralaya, Kolkata. And Dr. Meenakshi Yadavdhar ma'am. She's a professor and senior consultant at Amrita Hospital in NCR campus. I'm really extremely thankful to all the faculties as well as the special discussant for this particular, for joining us for this students episode on Journal Club. Now I would request our member ARCEs, Dr. Kasturi Bhattacharya madam, to carry forward the proceedings. I would be excusing myself as I have a further travel plan. So just over to you, Dr. Kasturi ma'am.
Thank you very much, Dr. Prashant, and thank you very much to all the discussant, the faculty, and also the presenters, the residents. So I think we'll straight go to the case, the first case presentation by Dr. Sneha, right?
Journal.
Yeah, the first journal. Sneha, are you ready?
Yes, ma'am.
Yeah, I think we'll go straight here.
Ma'am, is my screen visible?
Yes.
Yeah, it's visible. Yeah.
I changed the as well. Thank you very much. I would like to thank Dr. Sanjeev Mittal sir and Anupam Singh ma'am for giving me this opportunity to present on this prestigious platform. I'd like to discuss about a systemic review and meta-analysis about red reflex test screening for neonates. This review was published by Amarty et al. In Indian Journal of Ophthalmology in the year 26 July, on 26 July 2021. The World Health Organization reports a worldwide prevalence of 19 million children with visual impairment, amongst which 1.42 million children face a wrenching reality of permanent blindness. So there is a critical need for effective screening tool to identify and address visual challenges in children. The current prevalence of childhood blindness is about 0.8 per 1,000 children. During the fetal and neonatal periods, there is rapid development of ocular system. So most of the visual functions are permanently fixed by 6 months of age. If the development is defective, it can never be restored to normalcy. So the red reflex testing is essential for early detection of vision and life-threatening abnormalities in neonates. As we all know, newborn with congenital ocular diseases are often asymptomatic at birth. Hence, red reflex testing can identify conditions such as high refractive errors, congenital cataracts, congenital glaucoma, retinal abnormalities, retinoblastoma, and even systemic diseases with ocular abnormalities. The objective of this systemic review is to establish the diagnostic accuracy of red reflex testing in neonates, and the goal of this study was to provide evidence for policy making to prevent and effectively manage congenital ocular disorders and support further research. The protocol for this systemic review was prospectively registered at Prospero, and it adhered to the reporting criteria outlined by PRISMA strategy. The analysis mostly focused on characteristics, specifically including the sensitivity and the specificity of the test. The population type under study was neonates who underwent screening with red reflex testing. So, as we all know, red reflex testing involves the transmission of light from an ophthalmoscope through the transparent part of a newborn's eye. A characteristic red reflex is produced originating from the choroidal pigmentation and the choroidal vasculature. An abnormal red reflex can result from factors like mucus, foreign bodies in theophyme, corneal opacities, cataracts, iris abnormalities, high refractive errors, strabismus, and retinal abnormalities. So if there is an abnormal red reflex test on screening, it would indicate an immediate referral to an experienced ophthalmologist for further evaluation. Because of this screening, it reduced the neonate's discharge before diagnosing congenital ocular diseases. This systematic review and meta-analysis was conducted in 2 stages of literature search. First was bibliographic data search. The last electronic search for this was conducted on 30th August 2020, and other sources were research question search to identify any potentially missed sources. The inclusion criteria in this study were studies recruiting neonates aging less than 1 month, and the diagnostic test accuracy studies, and studies detecting ocular abnormalities using the red reflex testing. Also, the studies using ophthalmologist examination as a reference standard for ocular abnormality detection. The exclusion criteria in this meta-analysis were studies which were unrelated to the accuracy of red reflex testing. It excluded all the review, proceeding papers, meeting abstracts, letters, notes, and editorial materials. Also, it excluded the studies lacking any essential data which was required. The study selection process was as follows. Like, all the studies were imported into EndNote X7 software to remove duplicate records, and 2 authors conducted initial screening by just reviewing the titles and the abstracts. Disagreements between the two reviewers were resolved through discussions with a 3rd review author. Opinion sought if consensus was not reached. The quality of the papers was assessed by Quality Assessment of Diagnostic Accuracy Studies 2 tool, and disagreements were again resolved through discussion and consultations. The statistical analysis was done by Metadis software, and calculations were performed for all included studies, including the specificity and sensitivity. Homogeneity among the studies was assessed using a chi-square test, indicating a statistically significant heterogeneity among the studies included. The results were illustrated using a forest plot and a summary receiver operative characteristics curve. The area under the curve was calculated to summarize diagnostic performance of the test. The Q index representing the point where sensitivity and specificity are equal was calculated at the end. The characteristics of the studies included in this meta-analysis are as follows. Initially, 98 studies were identified for this meta-analysis, and after going through the process of screening and undergoing the eligibility criteria, finally only 11 studies were included for this meta-analysis. So the characteristics of the included studies are as follows. Like, the studies included were published between 2010 and 2019 with 5 studies from Asia, 2 studies from Europe, and 4 from American continent. 56,556 total participants were included in the study, with the age group being 24 hours to 28 days of life. And the outcome of interest of this meta-analysis was ocular abnormalities detected by red reflex testing in neonates. So as per this chart, we can see the baseline characteristics of the studies included. It included the author, year, country, the study design, the screening age, and the eyes for which the red reflex testing was done, and the name of the instrument used for testing, and who did the test. And also it included the name of the reference test done by the ophthalmologist. The other characteristics included in the meta-analysis were the year of the publication of the study, the population upon which the study was conducted, the sample size and the result categorized in a 2x2 table of true positive, false positives, false negative, and true negatives in the study. Detailed ophthalmological examination using an indirect ophthalmoscope served as a reference test, which independently assessed from the results of the red reflex test index test. Most reviews found no hindrances to the applicability of screening in terms of participant selection and reference pattern performance. The quality assessment of all the 11 included articles in this meta-analysis was done by SQUADAS 2 tool. And 9 out of 11 studies had low applicability concerns in all domains. So it resulted in an overall low applicability concern. The results of this meta-analysis were as follows. The pooled sensitivity of this red reflex testing for diagnosing ocular abnormalities was 23%, and the pooled specificity was very high to a number of 98%. And the positive likelihood ratio was 32.52, which indicated a strong evidence for the presence of disease. And negative likelihood ratio was 0.69, which suggested a low false negative with this test. Diagnostic odds ratio was 138.48, which indicated a high discriminatory power of red reflex testing. And the area under the curve was 0.98, which implied an excellent discriminator of ophthalmological abnormalities in neonates. So as per this forest plot of sensitivity and specificity for red reflex testing, we can see the sensitivity of different studies. So most of the studies were having a sensitivity at 0.2. So the pooled sensitivity of this study was 0.23. And among the specificity, most of the studies found that this red reflex testing was very specific for identifying ocular abnormalities. So the pooled specificity of this meta-analysis was 0.98. The prevalence of the ocular abnormalities as per the meta-analysis varied from 0.01% to as high as 30.9%. And it also found a significant variation in sensitivity across studies, which ranged from 0 to 99%. Some studies also reported that red reflex testing had a high rate of false negative for posterior segment abnormalities, contributing to its low overall sensitivity of 23%. Red reflex testing was excelled in detecting anterior segment abnormalities with a detection rate of 99.22%. However, the performance in identifying the posterior segment abnormalities was significantly low, with the detection rate of only 14.10% as opposed to 99.22% for anterior segment abnormalities. So in this chart also, in this table also, we can see there are very few anterior segment abnormalities that had been missed by the red reflex testing. And if we see the posterior segment abnormalities which had been missed, the number is very, very high on this side. So there were concerns about the red reflex testing, and the recently proved one was neonatal conjunctivitis. As per some studies conducted by Lenowski et al. And Smolkin et al., reported a significant relationship between clinical neonatal conjunctivitis and red reflex test performance. However, the complication can be prevented through proper hand hygiene using alcohol-based gel disinfectants. To conclude, I would like to say that the red reflex testing demonstrates high specificity, and a pool sensitivity may appear low, but it is valuable for detecting anterior segment abnormalities. Red reflex testing specificity remains consistent regardless of the type of abnormality. And this review also lays the groundwork for assessing the cost effectiveness of this integrating this non-invasive technology into newborn screening, particularly in low and middle income countries. The strengths of this meta-analysis that it included comprehensive and rigorous search, and there was no any language restriction for the studies included. It also followed the standardized quality assessment SQUADAS 2 tool, and the exploration of possible causes of heterogeneity and quantification was done. Calculation of diagnostic odds ratio, positive likelihood ratio, and negative likelihood ratio was also done, and diagrammatic representation of area under the curve of ROC curve. The limitations of this study, however, were limited number of studies which evaluated the red reflex testing for ocular abnormality detection was there. There was non-uniformity in individuals performing the test among the included study, and lack of consistent expertise was also seen in red reflex test performance, which led to false positives and false negatives. And there were possible unexplained heterogeneity in accuracy index and also variability in prevalence of abnormal ophthalmological cases and sample sizes across studies. So this is to summarize the study. To conclude, I would like to say that red reflex testing is highly sensitive and specific for detecting anterior segment abnormalities in neonates. Thank you.
Thank you, Dr. Sneha. That was a very nice presentation. And I have with you your mentors, Dr. Sanjeev and Dr. Anupam Singh. Sanjeev, sir, would you like to add something, sir?
Yeah, Dr. I would actually ask Dr. Anupam to just summarize, please.
Yeah.
As far as this methodology and reflex testing is concerned, if it becomes routine practice, it would be very helpful in our scenario because our country belongs to a middle and low income country. And the thing is, the only thing which is of concern is low sensitivity for posterior segment abnormalities and who is going to perform. So if we make it a part and parcel of neonatal screening and it is done by neonatologist only, and whenever they get any doubt, they can refer the case to ophthalmologist. The thing and the good thing about this test is very, very specific and sensitive for anterior segment abnormalities. Those things are also very high in our scenario. And the only thing I found the merit and limitation about this meta-analysis is that, however, we they included multi-ethnic population and multi-ethnic studies, but the sample size was very variable, and the person who performed the test was not uniform, and the way they performed in scenario, in which condition they perform, whether the test was performed in a labor room or whether in a ICU, not mentioned. And this is very, very important. And distance of RRT was also variable among all these studies. So our finding can vary, and that's why it led to so much of discrepancy as far as posterior segment abnormality is concerned.
Meenakshi ma'am, would you like to add something? Would you like to discuss this paper? This presentation? Yes.
Thank you, Dr. Kasturi. The thing is, was it done in dilated pupils or undilated pupils across those different studies?
That is also variable.
Yeah, that is one thing. But all in all, I must say that it's something like something which can be made a compulsory thing to do a red reflex test. If nothing else, the anterior segment abnormalities will be detected.
That's true.
Which is very often missed, like something like a large cornea, congenital glaucomas are missed. And the fact is that the most common retinal pathology which is there is also related to, which is retinopathy of prematurity. The population at risk is itself should be screened. So that way we will end up screening, if we remember, to screen all our ROP, the predisposed children, as well as do this anterior segment screening. At least we will be picking up very high number of cases. I was a little concerned about the low pooled sensitivity being around only 23%. So
it was not very good for detection of posterior segment, but when it come to anterior segment, it was 99.22%. Yes. So sensitivity was very high for anterior segment also. So
yeah. So I think actually, just like I realized that in now for every child, they do a testing by which they can come to know whether the child can hear at birth or not. So, and this should form a part of, this is an initiative which we ophthalmologists should take, that when a child is discharged from any nursery after birth, and at least all of the hospital births would be covered, and we will not miss such deficiencies in and such abnormalities in children.
That's true, ma'am. This should be mandatory.
Yeah, thank you.
Yes, ma'am. I feel this Bruckner test, the red reflex, is very important, especially even for some of the very dangerous posterior segment disease like retinoblastoma. Like once we were, when we were doing the ICMR registry, so there was a decision, like not decision, there was discussion if it can be brought into the immunization schedule, like every children during the immunization, if they have
Yeah,
this.
very, very correct. But here, since this is a test was basically for neonates, but this test is really good. What you're saying is correct.
Okay. Dr. Sujata?
Yes, so like we have seen the entire discussion going, it is sensitive for anterior segment. That means if we see a red reflex test positive, we definitely we can be sure that it is not. If it is positive, then we are sure that there is something wrong. But if it is negative, it means that we cannot rest assured that there is no retinal pathology. So I think as a screening tool, of course, it is very important, but over a period of time, we must emphasize that all these children should have a ophthalmologist follow up. This paper came from a pediatrician. It is a pediatrics department paper, if you see. It is not an ophthalmology department paper. So a pediatrician, I think it is mandatory that we teach them red reflex testing. And another thing I saw in this paper, that bilaterality, if it is bilateral pathology, say bilateral high refractive error, you might miss it if you are not very trained in looking at the red reflex. If it's symmetric pathology, you might miss it. If it is asymmetric, then they can compare with the other eye and they can pick it up, especially the non-ophthalmologist. So yes, this paper highlights the fact that it is a useful tool. This paper also highlights the fact that retinal pathologies can be missed. So if we find the red reflex test negative, that does not mean that we can kind of be complacent. It will be a good idea to send these children for a follow-up to an ophthalmologist at a later date. And if they are high-risk children, like premature children, they should be sent to an ophthalmologist, even if it is negative. That's what I think the paper kind of stresses.
Sanjeev sir, would you like to summarize the whole paper and give your inputs?
Yes, madam. Actually, what I feel like this is a tool. Basically, when we talk about at community level detection, all the newborns, everyone, they cannot be brought to the hospital for checkup. So at that level, actually, this screening tool can be adopted. So in that way, it's something very nice. Like when we are talking about ROPs, so in general, actually, for as an eye checkup at that stage, so the pediatricians can be taught for this. They can be encouraged to use this. So this is basically what I, in fact, feel like as a carry home message, such a tool which can be adopted in masses.
Thank you, sir. We all agree that this is a very important tool to detect the early disease. We can salvage the eye vision of many of the sight-threatening disease. So thank you very much. I think we will go to the next topic by Dr. Priyanka. Dr. Priyanka, who is a DNB resident from Sadhguru Netralaya and from Chitrakoot, and she'll be speaking on a very important topic. Her journal topic is effect of low concentration atropine eye drops in myopia. So over to you, Priyanka.
Good evening, ma'am. Is my presentation visible to you?
Yes, yes.
Okay. Very well. Good evening, everyone. So at the outset, I would like to thank Prashant sir, my mentors, and the Academic and Research Committee AIS for giving me this opportunity to be a part of postgraduate program. And I'll be presenting my topic, the effect of low concentration atropine eye drops versus placebo on myopia incidence in children, LAMP2 randomized clinical trial, which was published in JAMA in 2023. So why are we talking about this today? It is because of the relevance of myopia in today's time. The burden of this condition has been on the rise in the post-COVID era because of the dependency on digital devices and the lower outdoor time. The prevalence in India itself has been estimated to be a staggering 48% by the year 2050. And various studies has been done to see the pharmacological effect on myopia, to slow down the myopia progression. But it is the need of the hour to shift our focus to prevent this disease altogether, or at least delay its onset, so that the risk of long-term complication can be reduced. So myopia is a worldwide public health threat with increased prevalence across many regions, especially East Asia. The condition is associated with excessive lobe elongation and higher risk of sight-threatening complications. It is irreversible once developed, and the early onset is associated with greater risk of higher myopia in later life. Lifestyle modifications such as increasing outdoor activities and sunlight exposure has shown to delay the onset of myopia. But we need additional strategies for high-risk children. Low concentration atropine has been one such intervention which has shown to reduce the risk of myopia progression and has been widely adopted in many areas, including Asia. The most common concentration used are 0.01% to 0.05%. But there is very limited data available to us whether the atropine is effective in delaying the onset altogether. And we also need randomized trial to find robust evidence on its efficacy and safety. So LAMP2 was one such trial which was conducted to see the efficacy of low concentration atropine in delaying myopia onset among children. So keeping in mind the similar research question, their aim was to evaluate the efficacy of low concentration atropine eye drops at the concentration of 0.05% and 0.101% for delaying the onset of myopia. It was a randomized placebo-controlled double-masked trial which was done at Hong Kong Eye Center between July 2017 to June 2022. The inclusion criteria was they took all the children between the age of 4 to 9 years without myopia who had a cycloplegic spherical equivalent between 0 to 1 diopter, the astigmatism of less than 1 diopter, anisometropia of less than 2, and at least one parent who had myopia more than -3 diopter. The exclusion criteria was ocular diseases such as cataract, retinal diseases, amblyopia, previous use of atropine or parenzapine, use of orthokeratology lenses, allergy to atropine, systemic diseases, and developmental anomalies. So, doc randomization was performed by an independent statistician, and the whole sample was divided into 8 strata based on sex, mean spherical equivalent in both the eyes and each. Here we can see the age groups were divided in 2 groups, 4 to 6 and 7 to 9 years, and each age group were further divided according to the spherical equivalents 0 to 0.5 diopter and 0.5 to 1 diopter. So the randomization into treatment and placebo group was done by an independent research nurse, and specified personnel was allotted for each step of evaluation. The drugs were pre-coded confidentially by the manufacturer, and all the people, project coordinator, statistician, nurse, investigators, participants, and the parents were all masked. Coming to intervention, the trial medications were pre-packaged identically in the same type of bottle, to drug concentration 0.05%, 0.01%, and placebo used was 0.9% sodium chloride. And the scheduling was once nightly dosage was given for 2 years. The follow-up was done under identical examination protocols. The first follow-up was 2 weeks after the baseline evaluation, and then 6 follow-ups were done up till 24 months. The preparation of drugs was done for monodosaging via aseptic innovative medicine. Coming to the outcomes. So the primary outcome was cumulative incidence of myopia, which was defined as the spherical equivalent of -0.5 diopter in either of the eye, and the percentage of participants with fast myopic shift. So fast myopic shift was defined as the shift of 1 diopter within 2 years. The secondary outcomes was change in spherical equivalent and axial length, and the exploratory outcomes were time of myopia onset, change in accommodation, pupil diameters, and visual acuity. So the following measurements were performed: distance, best corrected visual acuity, near visual acuity, near point of accommodation and accommodation amplitude, pupil sizes, spherical equivalent, and axial length were all done with these methods. So at the baseline, 12 and 24-month follow-up, the 25-item National Institute Visual Function Questionnaire and validated questionnaires were used to assess the outdoor and near work time, which are the risk factors for developing myopia. And at each visit, any adverse events was documented, whether or not it was associated with atropine use. For treatment adherence, each participant's family had to keep a diary, and the mean weekly use was checked. So 5.2 days a week was taken as 75% adherence, and it was taken as good adherence. The sample size calculation was based on a pilot data, wherein the myopia onset rates over 2 years were taken as 6.6, 14.6, and 20% in 0.05%, 0.01%, and placebo groups. So the initial sample size calculated was 474, taking in the attrition rate of 20%, but the final sample size was 375 to achieve a 90% power. Descriptive statistics was used to summarize the baseline demographics, clinical characteristics, adverse events, and questionnaire results. Categorical variables were summarized as their frequencies and percentages, and continuous variables as their mean and standard deviations. They did analysis for each group. For the primary outcomes, logistical regression was done with 10 analysis to look for effectiveness of atropine. Sensitivity analysis was done using covariate adjusted analysis, and difference in incidence rates was calculated using Farrington-Manning score. For secondary outcomes, generalized estimating equations was used to see the correlation between both the eyes, and sensitivity analysis to control the confounders. And the analysis for both right and left eye was done using linear regression model. The exploratory outcomes were assessed by Kaplan-Meier method, and the dropout using univariate logistic regression. All the statistical tests were two-sided, and the p-value of less than 0.05 was taken as statistically significant. Coming to the sample size. So initially, the 740 children was assessed for the eligibility, and after applying the inclusion and exclusion criteria, 474 children were randomized into 0.05, 0.01, and placebo group. 116.05, 159.01, and 155 in the placebo group. So by the end of 2 years, 121 children dropped out, and the major causes was loss of follow-up, unwillingness to use the eye drops or undergo examination, and emigration. But the overall dropout rates were similar in all the three groups, and by the end of 24 months, 116 children were included in 0.05% group, 122 in 0.01%, and 115 in the placebo group, who underwent the primary outcome analysis. Oh, 1 second. Next, coming to the results. So the baseline demographic data, that is age, gender, body mass index, axial length, and spherical equivalent, were similar in all the three groups. They even did the risk factor analysis, wherein outdoor activities was measured in hours per day, near work in dioptric hours per day, and the parental history of myopia was also taken into account, and it was similar in all the three groups. Coming to the primary outcomes, so as we can see, the myopia incidence was 28.4% in the 0.05 group, and as compared to the 0.01% and placebo group, it was a significantly less value. So the 0.05% significantly reduced the cumulative myopia incidence at 2 years. The similar result was seen in the fast myopic shift, wherein the 0.05% atropine significantly reduced the percentage of participants with fast myopic shift at 2 years. This is a box and whiskers plot, and here we can see that at 24 months, this change in the spherical equivalent is the least in the 0.05% group. So here in the box, you can see the horizontal line represents the median, and the dot below it gives us the mean value, which is the least negative for 0.05% group. So it was least in this and had statistically significant difference as compared to the other two groups. Similar result was seen in change in action length, wherein 0.05% atropine group had the least change in the axial length, being 0.48 millimeters. This is the Kaplan-Meier graph showing the exploratory outcome cumulative myopia incidence. As we can see in this graph, that the 0.05% atropine group had a lower cumulative myopia incidence, and it suggests a delay of myopia onset with its use. Among the other exploratory outcomes, the pupil size had a significant difference among the three groups. Photophobia was the most common adverse effects in all the three groups, and 16 other severe events were there, but they were not related to atropine groups. And vision-related quality of life had no significant difference with a p-value of more than 0.05. Coming to the principal findings of this study, there was a lower incidence of myopia and lower percentage of participants with fast myopic shift at 2 years with nightly use of 0.05% atropine. 0.01% atropine did not achieve a statistically significant difference compared with placebo, and there was good tolerability with both concentrations of atropine without severe adverse events. The results, however, could not be interpreted as prevention or decreasing future risk of myopia because it had a limited duration of 2 years. But this study provides evidence for atropine to be used as an additional strategy to delay the myopia onset and can be considered for children who are at higher risk of developing the condition. This study was quoted in the discussion part, wherein 0.025% atropine eye drops have also been used to prevent myopia onset and myopic shift in pre-myopes for a duration of 1 year period. Coming to the limitation of the study, there was potential for unmasking participants due to atropine-induced mydriasis. But the authors have stated that complete bilateral cycloplegic regimen was given before any evaluation, and all the investigators were masked. The study population was homogeneous, so there is limited generalizability of the results. Third, it was a single center study and requires external validation. There was high participant dropout rates, which could have hampered the statistical power, but the authors have mentioned that it was not related to the treatment group and did not affect the main results. Next, the sample size was based on the primary outcomes, so it might lack statistical power for the secondary and exploratory outcomes. Next comes the effect of COVID-19 pandemic, which would have diminished the effectiveness of the treatment, but the proportion of children who were enrolled before the pandemic were similar in all the three groups, so it is less likely to affect the results. Next, the information on the treatment adherence was collected from parents by self-report, which could have induced a recall bias. And finally, the final myopic state of the participants requires a long-term follow-up. So they did not mention what was the final myopic state. And there is a continuation of the study for the same reason. The participants are currently in their 3rd year of follow-up, and the expected follow-up duration is 6 years to evaluate a long-term effect. To conclude, among children aged 4 to 9 years without myopia, the randomization to nightly use of 0.05% atropine resulted in significantly lower incidence of myopia and lower percentage of participants with fast myopic shift at 2 years. But further research is needed to replicate the finding and to understand whether this represents a delay or prevention of myopia and to assess long-term safety. So these are my interpretation and highlights of this study. So the title was a descriptive one, and it had optimum number of words capturing the main theme. It involved the population, intervention, comparison, and outcomes. The introduction laid a scientific background for the study, and the explanation of rationale was done with a specific objective. Coming to methodology, the study had an elaborate methodology with double blinding done, and monodose formulation and maintenance of diary was done to check the drug adherence. So it gives that it was a reliable source. Then primary, secondary outcomes were precisely defined. Randomization sequence, allocation, and implication was well performed. However, the authors did not mention the reason for including 4 to 9 year old children. again, it was a single center study and having only Chinese population under the inclusion criteria, and the questionnaire based data, that is the indoor activity and the outdoor activity, was just done 3 times at baseline, 12 and 24 months. So it might have had a recall bias. Then how did they recruit the population was not defined, whether they are doing regular screening of the younger age group, or whether the children were accompanying their parents, or whether there is a ongoing screening school programs from where they have recruited the study population. So there was a query there. Coming to statistical analysis highlights, thorough group analysis and dropout analysis was done. They provided participants flow chart and supplement tables for all the findings, and estimated effect size with its precision was given. However, they did not provide absolute spherical equivalent values in those who developed myopia. And for 90% power, the sample size calculated initially was 375 participants, but the final sample size was 353. The discussion was short but practical, with limitations well described, and the research question was answered in their study. But they had limited comparison with other studies, and they repeated the text used in discussion in the conclusion. So the question now is, can this study bring a change to the current clinical practice? The answer to this is 0.05% atropine in Indian scenario needs further research. So as to what should be the criteria of the treatment, when should we start the treatment, what is the efficacy, the safety profile in the Indian population, and what should be the duration of the treatment so as to prevent and stop the progression. So now I'll conclude my study. Thank you.
Thank you, Priyanka. Very well presented. And now we have two of the very young and dynamic mentors. So Dr. Pragna and Dr. Chintan. So Dr. Pragna, would you like to add something?
So it's a very well conducted RCT, and as Priyanka highlighted all the points, I would like to comment on the manuscript. Like if you go to the title, as Priyanka said, it's a descriptive title, which is the most preferred one. And this is usually preferred because it does not reveal the result. So reader's mind is always open to make his or her own decision. And if you look into the research question, it is well formed, well constructed, as considering the PICO-like population, what intervention they have done. It's a comparative study, and outcome is also involved in the research question. Once we go to the introduction, they have commented from the broad topic to a specific question. They have conducted the study, they have used a good methodology, and they have done the thorough statistical analysis, including they have included the supplements. And if you go to the conclusion, they have answered their research question. So this study not only gives you whether we should, this is a question whether we should use this atropine to prevent or delay the onset of myopia, but it's a very good, the manuscript, how one should write the manuscript. They also have give a very nice manuscript. That's it.
They have mentioned in the study that they are using it for 2 years. So they did not mention that were there any rebound effect after stopping it like beyond 2 years, right? So any analysis has been done on that part?
They have not yet stopped the study. They are continuing this further up to 6 years, because the duration of study, like we don't know how much time we should continue this treatment to delay the onset of myopia. So they are continuing this study. So there is no, they have not studied the rebound phenomena and all.
Okay, Dr. Chintan, are you there? Dr. Chintan?
Yes. Am I audible?
Yes, yes.
Yeah. So we have discussed a lot about these studies, but there are a few questions in my mind that further needs exploration and further research. For example, what concentration of atropine is ideal. So in India, we have mostly used 0.01% of the atropine. So in this study, 0.05 has been used. And if you go through the previous research, the people have used many different concentrations of atropine from 0.005, 0.025, 0.01, 0.25, 0.1. So actually, we don't know the optimal concentration of the atropine that can be used in our patient. Another thing is, if we start atropine at a tender age of 4 to 5 years, then can we give it safely for further 10 to 12 years without stopping the atropine? That is also need to be analyzed, because at present, we don't know the long-term safety profile of the atropine eye drop. Yes, we are giving it, but we don't know till how much duration we can give it safely. So that is another important concern. Regarding this study, I have one query that they have used two concentrations of atropine, that is 0.01 and 0.05. Now, on paper, it looks very minute, tiny quantity of atropine. But if you compare 0.01 and 0.05, that is actually 5 times more than 0.01. So, why they did not include an intermediate quantity like 0.025? Because they did the similar study in myopic patients where they used 0.025 concentration. So, comparing a molecule at a particular dosage and then comparing with it 5x dosage, I think that comparison is slightly causing some imbalance to the study. So there should be multiple concentrations of the atropine that we need to assess in our patient. We need to assess for how long it can be given. There are still many questions, and I think within the next few years, we will have many studies which can possibly answer these questions.
Yes, I think there has been an Indian study, no, with 0.01% in, preventing the progression of myopia. I think it was published by Dr. Rohit Sakai Atom or some study like this was there. So they found that 0.01% is very effective in Indian children. So, yeah, Dr. Pragya?
Yes, it is for the progression. This study is for delaying the onset of myopia. Like this study has been done in a pre-myopes.
Mm-hmm.
Yeah, that is a valid point.
So
a very
study-
important study, actually. It is one of the fewer studies which has actually discussed pre-myopes, and the pre-myopes are the group which we should actually target now. Once they become myopes, they will progress no matter what. So now we have to actually target pre-myopes, and we have had an Indian study. Dr. Jetani has published an Indian study in pre-myopes where he has used 0.01% atropine. And this study, the only thing I find is that 0.05 in ATOM study caused a lot of rebound as compared to 0.01.
That is a major.
This particular study's results are a little different from that of the ATOM. ATOM found 0.01 and 0.05 to have similar efficacy in the progression, but 0.05 had a higher rebound, for which they actually said that 0.01 will be a more safer concentration to use. But this particular study has actually found 0.01 and placebo to be the same as far as pre-myopes are concerned. So there are a few concerns about this. One concern would be the rebound, which will happen after they stop. The second concern is that how long to continue. The study it is a 2-year study. It has not discussed that. The third concern will be the 0.05% atropine may not be available. We are also enrolling participants with a 0.05 in specific centers. Our study will come off in some years, but yes, 0.05 is not commercially available, so we can't really put it to clinical practice as of now. So these are the few things that take home, but it is a very, very relevant study because it actually targets pre-myopes, which are the population group that we should look at now.
I agree with Dr. Sujata, and moreover, what we need to also know is they have not commented at all on the prevalence of myopia or its progression in their population. So that would have a relevance of how many turn from pre-myopes to myopes at different ages. That has not been mentioned at all. And then again, when we are talking of pre-myopes, they are not really said that what was there, where they have not at all related it to playing outside or how much of study time they had. And those things could have been analyzed a little further, and they just put them down that they all were equal. And as if that they had to already, it was a premeditated thing that they want the drug to be more effective.
And between the two studies, what I have come to know, the LAMP study and the ATOM study, with the two concentration, one with 0.5%, one with 0.1%, do you feel that adverse effect due to this myopia will differ because of the two different concentration?
It should,
Certainly. And yeah, please continue.
Ma'am, please carry on. I think the very relevant point, the adverse effect must be more, and it has been reported in previous study, ATOM-1. And rebound, as Dr. Sujata has already mentioned, rebound will be definitely more in 0.05. And one more important thing, we are subjecting higher concentration drug to a pre-myopia, which population has not even developed the myopia, and validity to our population, and prevalence, as Dr. Meenakshi Adhar ma'am has pointed out. Prevalence, their population is totally different. So confounders like lifestyle, near activity, outdoor activity, and near work duration. Sleep duration should also be considered. Recently, so many meta-analysis has come over that sleep time, sleep duration, and quality of sleep also affects myopia progression by circadian rhythm, affecting melatonin and serotonin and all.
And they've also talked of using progressive glasses for people who are having difficulty. All those things are very impractical solutions to the side effects.
Yes, ma'am.
And Dr. Sujata, do you think that all this medicine affects the axial length elongation, or it will not affect the axial length elongation? What is the concept like?
No, the concept is, yes, it affects the axial length elongation. So the study is done with the spherical equivalent and the axial length also. So when we put these children on, we don't put pre-myopes till now, but when we put these progressive myopes on atropine, we will always do a axial length calculation at the onset. In the follow-ups, it is actually recommended, and it is a standard of care.
Because I remember the ATOM study has mentioned that it does not affect the axial length elongation. So like, how does it control? Like, what is the main mechanism, how it is controlling the myopia? So, see, atropine is generally associated with accommodation, but it is not accommodation which is actually the culprit or which is the targeted mechanism. It is the scleral glycosaminoglycans which are altered with these atropine. Atropine kind of upregulates dopamine, which affects the scleral glycosaminoglycans and thus prevents scleral elongation. That's how atropine is one of the theories that atropine is supposed to address. It down-regulates serotonin, up-regulates dopamine, and dopamine is the preventer of scleral elongation, whereas the serotonin is the it increases the thing. So that is how it acts. Atropine, one of the factors. We actually don't know specifically. This is one of the theories. Sanjeev sir, would you like to add something to the second presentation, sir? Sir, you're muted, sir.
Yeah, sorry. Two points I want to make it here. Like first, like when like we did a study, like we keep on putting atropine for longer duration, and we all know that this is also systematically getting absorbed. So long-term effects, in fact, like we are putting something to a child, so that has to be actually seen in long term. What systemic effect it can happen. Secondly, I think like it calls for another like one study like where we can compare the children like in this study between the age of 4 years to 9 years where the myopia was not started and as a prophylaxis we used versus the second group where we are giving it to reduce the progression, where there are established cases of myopia where they are using lenses and we are providing this drug to control the further progression. So I think that can also give some impetus into this. That's it.
Thank you, sir. Yeah, ma'am.
Yeah, can I add one point? They have not talked about like atropine causes allergy in some percentage of users and we always advise the children who are getting cycloplegic refraction done to be the parents that this may occur. But there is not a mention of any of the children on the low dose being having any allergy. That would be interesting to know as to how often that happens. Any of the faculty can throw some light on this, or any of the participants?
Ma'am, actually, in this study, they have mentioned that all these factors, the environmental factors, the adverse effects, all were similar across all treatment arms. And this information is provided in supplementary tables. There are, I think, 10 to 12 supplementary tables and figures where they have given in detail what all adverse effect happened and all. So the allergic reactions, the photophobia, and all adverse events were similar except for the pupillary dilatation. So pupillary dilatation
that's not what I'm talking about. That's not what I'm mentioning. I'm saying how often was allergy to the low dose atropine found? Since you are saying there are accessory tables, then could the presenter throw some light? She's looked at the accessory tables.
Yes, ma'am. Ma'am, among the other side effects, can you hear me, ma'am?
Yes,
Can
yes.
Right, Priyanka?
Yes, ma'am. Ma'am, among the other side effects, there was use of photochromic glasses, progressive glasses, and allergic conjunctivitis also, as you rightly mentioned. But the percentage was very less, just one out of all the participants, or just 2 out of all the participants in 0.01% group developed allergic conjunctivitis.
See, my point is not that. My point is when we find normally when you must be also observing that a certain number of children whom we advise atropine for cycloplegic action, if they end up having red eyes or allergy to the thing, and we stop it. So was that found in any of the participants? I'm not saying not only in this study, but I was just intrigued whether that has ever come up as a problem whenever we are giving low dose atropine. If
I
haven't.
A few children in my practice did have allergy to low dose atropine, and I don't think it was the low dose atropine which was the culprit. It could have been the preservative which would have been the culprit, and we have stopped it. It has been in my practice, but the percentage in ATOM also was very low, and even in our clinical practice also it is very, very low.
Thank you, Sujata.
Okay. So before we conclude, I think there is a video. Mr. Sunil, you are there? There's a video from Dr. Ramesh Kekonaya, who has sent a video to be played. Anyone from the IT section who can play
Yes, ma'am. Should I play it?
Sure. Now, I think Priyanka will have to. Yes,
yeah, ma'am. I'm just playing.
Hi everyone. Sorry that I could not be online because of my flight rescheduling. Thank you for sharing both the articles. Both of them are very nicely done studies, especially the second one. The first one was more like a review article. If you look at the LAMP2 study, more and more evidence is saying that 0.05 is significantly leads to less progression of myopia. And also one of the things we need to remember is the quicker myopic shift also is less, because this is also as important, because sometimes we still see the progression in some of the patients, and it's a very fast progression. So the 0.05%, I think if you look at the study, it has got significantly less in the 0.05% group compared to 0.01% or placebo. One thing was very, very surprising is that they saw side effect of photophobia in all the group, both in placebo and 0.01%, and also obviously in 0.05% where the concentration is higher. Photophobia was, if you look at the study, it was seen in close to 13% of the participants with 0.05%. That was a little bit surprising for me. And this study particularly included patients who are 4 years and more. If you look at the earlier studies, like ATOM study, the patients were more than that age group, specifically 6+. This is 4 and 9, which I think it's a good thing, because somewhere at 3.5, 4 years, we can start this treatment. That is good to see, especially with the inclusion criteria of 4 to 9 years old age group. And also, they've not really gone post-pubertal age group, which is again nice to see. One of the things I had specifically comment was that this particular study was done in COVID period. So we really don't know whether the inherent risk of myopia progression because of the more screening time, that particular thing may be a bias in this group. How it really applies to our population, how can we extrapolate? I would say that there is a strong evidence that higher the dose, it's better. But 0.05% is a very good balance between low dose and little bit higher dose. Only thing is the rebound phenomenon over a period of time. How it happens, we don't know. But otherwise, if for our population, I think pharma companies are working. If it is available, I think it's a good thing to start 0.05% in most of the patient. And more evidence, even if you look at the publication from JAMA, I think the 0.05% makes sense. That is the take-home message I would like to take from this study. And obviously, there are a lot of statistical things we can talk about. In view of time, I think we can keep it for another time. Just a few things about the other study, that is the red reflex test. For me, it was enlightening to see that this review is written by a pediatrician than an ophthalmologist or a pediatric ophthalmologist. That was a significant difference, because in India, we need more and more non-ophthalmologists to see this, use this red reflex test and, send the patient to us. Other thing was that the final review papers, which are finalized, were from 9 different countries. If I look at it, they are all from different countries. And only thing is that they used different instruments to confirm the thing. Sometimes they use fundus camera, sometimes direct distance ophthalmoscope. That was one thing which was missing. And there was a combination of ophthalmologists as well as pediatrician in this study group, finally, whatever they have selected. the final 11. But specifically in the second article on the table, there are a lot of false negative, which I was really surprised. That was the largest population studied in this group of review papers what they've shared, but they had a maximum of false negatives in that. So that was a little bit surprising. As we look at it, RRT is a very, very, very good test in identifying mostly the anti-segment pathologies and sometimes post-segment pathology like coloboma, retinoblastoma, and of course, any other kind of refractive errors or Coats disease and things like that, because it all depends on where the child is looking at. So it's not so simple for an ophthalmologist. It's a simple test. It's really difficult to do it on a large scale. As you all know, there is some instrument called ArcLight. It's much cheaper than direct ophthalmoscope, which is developed by Andrew Lake. He is in Scotland. That's one of the things we can use more and more. I do not have any financial interest, but to teach to the healthcare professionals, be it nurses, be it Anganwadi workers, or be it pediatricians, it's pretty useful. And also you can carry it all the time in your pocket, and the charging for that is through solar. So these kind of innovations are important to reach to more and more children and to perform red reflex test. All in all, I really enjoyed reading this meta-analysis. It was a good collection of all the reviews. And thank you for the opportunity for today. Unfortunately, I could not meet all of you online. Thank you.
So thank you, everybody. Thank you to all, both, this presenter, Dr. Priyanka, and also Dr. Sneha. Very well presented by both of you, being so young and being in the residency program. And I would also like to thank the mentors, Dr. Sanjeev Kumar Mittal sir, Dr. Anupama Singh, Madam Pragnya Sen, and also Chintan. And also to the discussants, especially my very dear friend, Dr. Sujata and Meenakshi Madam, for giving all the time and also supporting us. This ARC PG program, we are really trying to make it the best. Every session, we see more than 3,000 viewers on Facebook Live and YouTube Live. So also we request you to give us the feedback so that we can improve further and make it a more interesting session for the postgraduate students. So thank you for all the valuable time and your effort. Thank you very much.
Thank you, Dr. Kasturi.
Bye-bye.
Just one question. Who chooses the article, the relevant?
By Mr. Dr. Prashant, and then he talks with the mentors, and that is how it comes up. And we have
wonderful idea. You were saying something.
We have a theme, like supposing if this month is screen, next would be, we started first with glaucoma, then came plasty, now screened pediatrics, and next I think we'll go to retina. In between we had a few, and every Friday, once a month, we have the webinars. And in the webinars also, we are trying to make it more of a case discussions.
Very nice.
Thank you, madam. And
enjoy.